Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. I welcome you all to our ongoing series of webinars to explore the science, the clinical medicine, and the community response needed to reach goals for elimination of hepatitis B and hepatitis C, and by extension, the elimination of Delta virus as a cause of morbidity for persons with hepatitis B. And that's our topic today. As you can see here on our title slide, I want to thank the collaboration with ICE-HBV in forming the agenda for the webinar today. And I want to thank in advance all the speakers and panelists that you'll be hearing from over the next 90 minutes. The information coming from the webinar is available on our website at globalhep.org. That includes the video and as well as the slide presentations. So I encourage you to go to that to receive the information that you'll be seeing over the webinar today. I'll be turning it over to our moderators in just a moment, but just to encourage you all to make this a very interactive webinar, to share your questions in the Q&A function of Zoom on the bottom of your screen, and to provide your comments in the chat function. And we'll be asking the speakers to respond to the questions relevant to their presentations in the Q&A function, so that we can make the best use of the technology to answer your questions while still making sure that there's adequate time for all the speakers. And then we'll have an opportunity for a rich discussion to conclude the webinar. And while you're at globalhep.org, sign up for our newsletters so that you can receive notices of upcoming webinars and other activities of the coalition in the future. So at this point, I want to turn it over to my colleagues, Massimo, Levrero, and Maura, Dandri, who will be serving as moderators today. Thank you.
Thank you, John.
Thank you, John, for the nice introduction. Also, welcome everybody from my side. Yes, Maura Dandri from the University Medical Center Hamburg-Eppendorf in Germany. And actually, I'm delighted for this, what is now a kind of series of webinars we have on the hepatitis Delta. This is the third one that we have the pleasure to organize together with the Coalition for Global Hepatitis Elimination, and with the ICE-HBV, with the International Coalition to Eliminate HBV. And so it's just, we're moving on. It's we choose to focus on some main topics on hepatitis Delta. We want to bring awareness to the global burden of hepatitis D, focus on the need that we have for research, policy, and implementation to expand access to HDV care. And we have three excellent speakers, and then later on four panelists, really distinct panelists, that will give us, I think, a great opportunity actually to review the latest guidelines for HDV management, to discuss the challenges that we encounter in HDV surveillance, testing, and also which are the treatment options. So I think with that, I will move on with the program. Well, you can see we will start with the HDV global burden and care cascade. So the WHO perspective, then move on challenging in HDV diagnosis and evolving landscape of HDV and chronic hepatitis D treatment. And with that, I would like to start introducing the first speaker, was Dr. Niklas Luhmann. And actually, he's a medical doctor who is a Master of Science in International Public Health at the University of Berlin and Copenhagen. And he has worked several years for the French humanitarian NGO, Médecins du Monde, on implementation research, healthcare system, infectious disease, He joins with the WHO headquarters in Geneva in 2019, and where actually he's working as a technical officer and leads the work on viral hepatitis B, D, and C prevention and testing. So I think it's the perfect speaker to start this webinar. So Nicholas, please, the stage is yours.
Thank you, Maura. Can you just say if you can hear me? Apparently it's fine. Hello to everyone. Thanks for John and Lindsay and the Coalition for Global Hepatitis Elimination and ICE-HBV to have me at this important webinar for hepatitis Delta. I will talk on epidemiology, cascade of care, and our recent recommendations. I work at the headquarters, if you have heard of WHO in Geneva. And thanks for joining here today. I just started, before I talk about epidemiology, I thought maybe there are some people who are still learning or starting to work on Delta. So just 3 bullets on a background, which is that hepatitis D virus is has been discovered in 1977 and is not as known as the other virus hepatitis strains. It really requires hepatitis B for packaging and release and transmission. So I think it's important to just, can everybody mute, please? To remind everyone that it can only infect people who have chronic hepatitis B as a super or co-infection, and its role in burden and morbidity and mortality, as stated by John, is as well underappreciated often by many. So in terms of epidemiology, the first thing I wanted to share, because as you now know, it can only occur as a super or co-infection of hepatitis B. Thus, I just wanted to quickly show from our recent access report that included data from around 180 countries, and that was released 2 months ago, the latest epidemiological estimates for hepatitis B, chronic hepatitis B, estimating 254 million people infected globally, with the main regions being the African and the both Asian regions affected here by chronic hepatitis B. Even maybe more importantly from this access report, possibly the main key message that came out is that we are estimating that mortality due to hepatitis B and C is slightly increasing. We're seeing now 1.3 million people dying every year from hepatitis B and C combined, with the main contribution coming from hepatitis B with 1.1 million annual deaths. And obviously this indirectly or directly includes the hepatitis Delta death. And so this is a very important data point, which points to the fact that this might be the only communicable disease area where we have increasing mortality across the world. In terms of hepatitis Delta epidemiology now, more focused on this, I'm here citing the systematic review and collaboration with the group from Alexander Stockdale and the 2020 publication, a global meta-analysis and systematic review that estimated that 4.5% among all people who live with surface antigen are positive for anti-HBV serology, and that was then calculated to be around 12 million people around the globe. That rate and prevalence was much higher in hepatology clinics. As many of you will know, there is some countries, and some are listed here, that are particularly affected with very high prevalence, and as well some groups that are disproportionately affected, including injecting drug users, hemodialysis recipients, men who have sex with men, commercial sex workers, and for example, those with Hep C or HIV infection. So this shows the map from this systematic review with the countries that included data points and the different estimates in the general population for anti-HBV serology prevalence in surface antigen positive people. And they estimated as well regional prevalence. And this one shows on the left in the red here in the general population, showing from 3 to 6% in the different regions. and suggesting that possibly the Afro and the Americas regions are those who might have the highest regional prevalence. This data set is now updated, and thanks a lot to Alexander Stockdale, who shared that with me. It has not been published yet at all. It's still all preliminary and has included more than 100 new updated searches. You can see on the right that there's been quite a good amount of new publications since 2019 and 2020. And again, this is preliminary and fully unpublished. He told me as well that he thinks that the general population prevalence may be coming out slightly lower with the new studies on a global level. And as many may know, it's really not always very evident to have good hepatitis delta prevalence estimates. This preliminary analysis from the same work will possibly show as well the population attributable fraction for cirrhosis in HCC, and pointing to the fact that delta contributes around 19.5% of cirrhosis cases in surface antigen positive people, and around 15% for HCC. So again, the contribution to cirrhosis and HCC is disproportional in some way from HDV. And if we relate that to the mortality figures that I've shown, I think that would really highlight that quite high number of people yearly die from hepatitis delta. We haven't done this particular sub-analysis yet at WHO. Another data set that I really like from Frédéric Legal, here focusing on Africa, shows, for example, here presented at AfroVIH 2020-40, that there's a huge amount of regional differences and a very strong concentration of high prevalence around the equatorial belt, for example, in the African subcontinent. And you can see even in countries such as Cameroon and Gabon, which are high prevalence, but huge regional differences, which points to the fact that there's regional, but even in-country strong differences in hepatitis delta prevalence. And there are really pockets of very high prevalence settings in certain countries, such as in Cameroon, for example. In terms of cascade of care, just a couple of slides. So again, I wanted to come back. I mean, if you think about the cascade of care, the first thing you have to do to find people with delta is you have to find people with chronic hepatitis B. And this doesn't show the cascade of care for delta. It shows the cascade of care for chronic hepatitis B from the same Access report, and noting that only 13% globally know their status for chronic hepatitis B. So there are regional differences, and some regions have a little bit higher rates, the Asian region, the European region, but really overall, there's a huge testing gap, and only once you know those people, you can then test for the presence of hepatitis delta serology. So closing this gap is crucial for closing the hepatitis delta cascade gap as well. In terms of the cascade, more specifically of delta, there's many studies that are shown in our guidelines, but as well in this paper from Stockholm, showing that historically, hepatitis delta testing in surface antigen people has been quite low to very low, depending on the setting, with some studies that I list here from Spain, from the US, and a little bit better testing rates in Greece. The cascade that you see below is the one from Stockholm that always had quite a good uptake of anti-HDV testing in this tertiary center. And that's a bit of an exception. But generally, one could say that, even for those who know or who have been diagnosed with chronic hepatitis B, often hepatitis delta assessment has not been done. I think this is improving, at least in many countries, or in the European context. For example, we know studies from France. Here's one from Barcelona showing that this is improving, and notably using the reflex testing methodology, and showing that, prior and after reflex testing introduction, really a much higher proportion of people with surface antigen are tested for HDV serology, and then sometimes with double reflex testing as well for HDV RNA. So I wanted to finish with just showing our most recent hepatitis B guidelines that have now formal recommendations for Delta testing and screening. So you can use that QR code if you want to go to the English guidelines. There's as well a link to the French policy brief of those guidelines. Before I show the recommendations, sorry, I will just drink a little bit. Before I show the recommendations, I like to always highlight the fact that WHO guidelines are a little bit different from other clinic society guidelines, for example, as in they're mainly targeting low and middle income countries. They're not only for treating clinicians, but as well national program managers that focus on a public health approach, and they're all completely evidence-based using the GRADE methodology. What was our rationale to developing now formal hepatitis delta testing and diagnosis recommendations? It was really, as I've shown already, the increasing understanding of the epidemiology, the contribution to morbidity and mortality, and the low testing and diagnosis proportions in people with chronic hepatitis B, and as well the need for improved surveillance, improved epidemiological data. We've been asked, obviously, why this update has not included recommendations for treatment, but it was felt, the expert group met last year, it was felt that there was not enough data yet on ideal dosing, ideal duration, and ideal and long-term outcomes from, for example, bulevirtide treatment. And we're monitoring this closely and thinking about when a recommendation can potentially be started. So the recommendations that we have developed is one on who to test. This is similar to the structure how we have made recommendations for hepatitis B and C, and there really recommends the universal testing approach as the preferred approach, stating that serological testing for anti-HDV antibodies may be performed for all individuals who are surface antigen positive. This is a conditional recommendation, and that means that it is recommended to do it that way, but it might be context-specific differences. And that's why we as well added an additional form of recommendation that states where really there are resource limitations to implement that, or laboratory capacity is not there. At the beginning, maybe countries can focus on specific populations that would include advanced liver disease patients, people with increased risk, or from high endemic countries or regions. The evidence for this didn't include any direct evaluations of impact or cost effectiveness, but the expert group discussed the findings from the observational studies from showing quite low uptake in risk-based approaches, and as well using some of the recent reflex testing, universal testing approaches. I just wanted, no, I will skip this. This will take maybe too long. Otherwise, the other recommendation is on how to test. This is pretty standard and straightforward. The algorithm on the right is showing the recommendation that people may be diagnosed with hepatitis D by using a serological assay first, and then followed by a molecular assay to detect HDV RNA. And then we have developed as well a reflex testing recommendation for reflex testing for anti-HDV antibody testing, and potentially double reflex testing to reflex on to HDV RNA testing where available. That was based on a systematic review that included 11 studies, for which you find some key outcomes on the right there. And so the rationale for the reflex testing recommendation was really the substantially increased uptake for serology, but as well in some studies for the onward reflex for molecular testing, and the benefits outweighed clearly the harms was felt by the expert groups. So just to finish, this is my last slide. Some implementation considerations, they're pretty straightforward, include the fact that countries should develop policy and guidelines, procurement plans, and train their healthcare providers and laboratory staff, and have to as well develop some counseling and linkage to care mechanisms and monitoring and evaluation systems. This is the acknowledgement of the expert group for the hepatitis B guidelines with a Delta co-infection subgroup, for which you can see the members. And I'm staying on to receive any questions, and will monitor the chat as well if people have any questions. Thanks.
Thank you very much, Nicholas. You're perfectly on time. No, no worry. And actually, there are some questions in the chat. I don't know. Maybe we can discuss later. Of course, the big question. We can see, I think, in the rounder tables later on, I would say. And Massimo, would you like to go on?
Sure, I go on. Thank you, Nicholas, for the beautiful presentation. I will introduce now Elisabetta De Gasperi, who is a medical doctor and acting as a hepatologist in the Division of Gastroenterology and Hepatology in the University Hospital in Milan. She studies in Milan, and she received also a PhD in clinical experimental medicine. She is quite active in hepatitis B and Delta clinical research, and she's involved in many phase 1, 2, and 3 and post-marketing studies in both chronic hepatitis B and chronic hepatitis Delta. But she was also very importantly engaged in hepatitis C a few years ago. We all know her effort there as well. We followed up that. And Elisabetta, is to you to talk about the diagnostics in challenges in HBV diagnosis. Is to you.
So thank you. First of all, I'd like to thank the organizers for the invitation. Apologies for some connection problems. And my topic today is challenges in HBV diagnosis. In the next 15 minutes, I will cover, next slide, please, 3 main challenges. Think about Delta, test for Delta, and resource-limited settings. Next, please. So the first challenge is think about Delta. We have seen the WHO recommendations. We all know that the recommendations for HBV screening differ according to international societies, while the EASL and the APASL recommend universal screening of all HBs antigen carriers. The American Association for the Study of Liver Disease only recommends screening in patients with specific risk factors that listed here. And we have heard from Nicholas that rates of HBV screening in real life practice are still low, with some virtuous exceptions, such as the Swedish study. Next, please. So the first challenge is how to increase diagnosis rates. We have heard the benefits of reflex testing, that is the automatic reflex testing of all HBV antigen carriers. We have heard some experience, the Spanish study already presented by Nicholas, and also on the right, a single-center Italian study that evaluated 1 year of reflex testing compared to a pre-reflex testing era. And of course, as you can see, the rates of HBV diagnosis peaked up to 90, 100%. However, please note that in the Spanish study, more than 60% of patients had no definite risk factors for Delta. So they would have been missed by a targeted screening strategy. Next slide, please. So the next question is the reflex testing also beneficial in terms of liver-related outcomes and affordable? So on the left, you can see a Spanish modeling analysis recently published, evaluating the cost effectiveness and also the impact on liver-related outcomes of the anti-HBV reflex testing. And as you can see, the implementation of reflex testing is expected to lead to a significant decrease in cases of liver cirrhosis, decompensated cirrhosis, HCC, and also liver-related death. On the right, a recently published analysis from the Polaris Observatory Group try to calculate the affordability for healthcare systems of anti-HBV reflex testing. They propose also a double reflex testing, both anti-HDV and also HDV RNA. So they calculated that giving 2 million new HBV diagnoses per year, given a prevalence of HDV worldwide approximately 5%, so 89,000 people who need annual HDV RNA testing. And so this strategy will not overburden healthcare systems. So next slide, please. So the second challenge is a test for Delta. So what is the current performance of available anti-HDV assays? These are the results of a national quality control study held in France for the diagnosis of HDV infection. It involved 23 labs evaluating both the anti-Delta total antibodies and also the IgM antibodies. So on the right, you can see the results. So for the total anti-HDV, labs were concordant for more than 80% of participating labs, and discrepancies were only seen for weak positive samples. The concordance rates for anti-HDV IgM were lower. However, during the study period, there were a decreasing number of labs using the anti-Delta IgM due to the availability of more specific HDV RNA assays. Next, so we have also some more faster and more specific anti-Delta assays on development. Here I put two examples. One is a collaborative study held across US, Europe, and Africa, evaluating a new assay for IgG antibodies, the Architect assay, that was compared to the reference standards liaison test. And as you can see, the Architect, the new test, outperformed the liaison for specificity, sensitivity, and predictive values, and best performed on the low viral load samples. If you see the yellow square, so the Architect missed only 3 samples with low viremia compared to 6 samples missed by the liaison test. On the right, a single-center Mongolian study tried to evaluate a new sensitive ELISA assay that is using a new technology for antigen immobilization that should grant for increased specificity compared to the traditional physical absorption method. And also in this case, the sensitivity and specificity were optimal. And please note that this assay had a low turnaround time, only 30 minutes. So next slide. However, we should also be aware that there are some cases of active infection in patients with anti-Delta negative antibodies. These are the results of the Prolifica project held in Gambia. They tested more than 700 HBs antigen carriers by both a point-of-care testing and also the diazorin test. And they found 28 patients with positive HDV RNA and negative antibodies, so 4% active HDV infection despite seronegativity. On the right, you can see the levels of viremia in these 28 patients. So you can see that they were very, very high, some patients with 6 logs of viremia. Of course, we cannot say that maybe these patients were in the window phase of early infection. However, so the message for clinicians is always perform the HDV RNA in case of strong clinical suspicion of HDV infection, so elevated ALT and low HBV DNA. So next slide. So we have heard about prevalence and also performance of a serology test. How about the HDV RNA quantification, so the virology? Here the field is more complicated as we have many available assays. This is only a partial list. As you can see, there are many tests with different lower detection limits, lower quantification limits, some tests reporting results in copies per ml, some others in units per ml. Some of them are research use only, other are certified. And please remember that the WHO international standard for HDV is obtained only for genotype 1 patients. So next slide. So how can we compare these very heterogeneous assays? I will show you 2 studies two studies. The first study that was presented at the last Delta Cure meeting tried to compare 7 different assays that are listed here, 2 from the Altona kits, 2 from the Eurobioplex, and 3 different versions of the Robogene commercial kit. Overall, as you can see on the left, these assays reported similar qualitative and quantitative performance. However, the Eurobioplex kit systematically overestimated by approximately 1 log the viremia. So you can see the light gray crosses, and was withdrawn from the market last year. And we had also some quantification problems on some strains of African HDV genotypes for the Altona kits. The next slide, the next study is the multi-center quality control study held in Italy, involving 30 centers. They evaluated 6 commercial assays for HDV RNA and 3 in-house assays that are listed here. And again, also in these cases, heterogeneity was higher, and especially concerning lower detection limits. And most assays had a drop in performances in case of low viremia below 1,000. And only the Robogene and the Altona assays had the best performances in very low viremias below 100. And this study was presented at the last EASL Congress. So we have seen the complexity in HDV RNA quantification across assays. However, to make things more complicated, next slide, please. I have to say that also HDV RNA quantification differs according to, in the same assay, according to different technologies and different extraction methods. This single-center Italian study, recently published, evaluated more than 200 samples from more than 157 patients, some of them bulevirtide treated. And we use the Robogene assay, but 2 different extraction methods, the manual and also the automated extraction. So if you can see on the left, the manual extraction in gray, dark blue, reported higher HDV RNA values, more than 1 log, than the automated extraction. And this was true both for untreated patients and also for treated patients during treatment, resulting also in different rates of HDV RNA undetectability on therapy. So the message is here, so don't get crazy. However, with all these assays, all the technology, all the extraction methods, however, please use always the same assay to monitor your patients in order to have the most reproducible results. So coming to the last part of the presentation, next slide. Some words about the resource-limited settings. We have many promising technologies for low-income countries, and this is one example, the dry blood spot technology. Dry blood spots can be stored at room temperatures for 2 weeks, so they are very user-friendly. In this French study presented in the last year Delta Cure meetings, they tried to validate a specific DBS cutoff for anti-HDV detection, and this turned up to be 100% specific compared to a commercial assay. Then they evaluated the qualitative detection of HDV RNA positive samples, and here again the sensitivity was optimal, and only low viral load samples were not detected. And now the prospective part with the whole blood on the DBS is ongoing. The second example I want to show you, next slide, please, is the rapid test for HDV. The rapid diagnostic tests look like very similar to some other rapid tests like COVID. They have only 5 minutes incubation period, and in this collaborative study, more than 200 samples were tested by the rapid diagnostic tests, and results were compared to the reference standard ELISA test and also in the in-house HDV RNA assay. And as you can see, there was 100% agreement between the rapid test and the ELISA test. So finally, we have also some technologies for the HDV RNA assay. Next slide, please. And this is one example, the LAMP PCR. LAMP stands for loop-mediated isothermal amplification PCR. It is a low-cost assay that doesn't need for specialized equipment. It has a visual colorimetric detection, so pink stands for negative and yellow for positive. And in this study, these samples were also retested with the standard quantitative PCR. And as you can see, there was 100% concordance on HDV RNA negative samples and just one false negative among HDV RNA positive samples. And this assay had a very, very low low detection, lower limit of detection. So to conclude, the next slide. We have seen that the HDV screening in HBs antigen carriers is currently underperformed in clinical practice despite international recommendation. So the reflex testing, both anti-HDV and also the double reflex testing, could be a helpful tool to maximize diagnosis. Anti-HDV is the first screening tool. However, please remember to perform HDV RNA assessment in case of clinical suspicion. Quantification of HDV RNA may significantly differ according to different assays and also within the same assay according to different extraction methods. And this heterogeneity prevents comparability, so please use always the same assay to monitor your patients. And finally, rapid user-friendly assays are in development for resource-limited settings. And with this, I would like to thank you for the attention, and I'm happy to receive questions. Thank you.
Thank you very much, Elisabetta. Great presentation. And actually, I think we will skip the question for the roundtables. I don't see that urgent question. So then it is my pleasure to move on with our third speaker, with Professor Heiner Wedemeyer. He's director of the Department of Gastroenterology, Hepatology, Infectious Disease at Hanover Medical School, so in Germany. As well-known gastroenterology, he has, I think, not only great expertise in treating, in seeing patients, but also worked as a research fellow in the past, as a research fellow in the immunology in the liver disease section at the NIH, Bethesda, some years ago, I guess. Right? It was just a few years ago. But I think that Heiner Wedemeyer really has a long list of commitment activity. Just to mention, he was appointed at the ISL as a Secretary General of the ISL. I think is being involved as investigator in many clinical trials of antiviral drug immunotherapy for viral hepatitis B, C, and D. And perhaps to mention here in this round, he actually he was involved from the very beginning in design in the first clinical trials with bulevirtides. So Heiner, please move on with your talk. We are looking forward, and we'll focus on the evolving landscape of HDV and chronic hepatitis D treatment. So from discovery to assess to care. Please, the stage is yours.
So thank you very much, Maura, for those very kind introductions. And thank you, everybody, for attending this, I have to say, really impressive webinar. This is, as we all agree, a very important topic. And I have to thank all the organizers and the board of ICE-HBV for putting Delta on the agenda. I think it's so important to talk about this disease, not only to discover the disease, but we have to talk about treatment. And as treatments are available, we have to identify the patients. We have to share experiences, how to manage these patients, and therefore I think these webinars are extremely important. So I've been asked to discuss this evolving landscape. I'm sitting right now here at Hanover Medical School in my office. You see we are a quite green city, and we have quite some groups in Hanover working or treating patients with Delta. This is the infectious disease ward. These are the outpatient clinic, but also doing some translational work to understand the pathogenesis. These are my potential conflicts of interest, which includes companies developing drugs against advanced HDV infection. And I have to acknowledge many people who are working here at Hanover on Delta, but also our collaboration partners in the German Center for Infection Research, including Maura, in different consortia, including the European-funded DSOLVE consortium. So we have, when we talk about treatment, I often ask about what are the options. I can refer to this guideline and stop my talk because last year we released Mauricia Brunetto. She coordinated the EASL clinical practice guidelines. Pietro was one of the reviewers of these guidelines. And you can see here this main figure. It states that we have two options. We have pegylated interferon alpha. We have bulevirtide. We may combine this, and the more advanced the disease, this figure suggests to use bulevirtide, and in the patients with a milder disease, you may use pegylated interferon. This is basically what's written at that time without too much evidence, I have to say, and we may discuss this later also critically, whether this is really holds true in the year 2024. But I think it's a nice scheme, and it's for the very first time that we really have international guidelines. My message today is really that, and that in contrast to hepatitis C, where we have simplified treatment, one-size-fits-all strategy, this is not the case for Delta, and for various reasons. Access to treatment, but also if treatments are available, one treatment may not be the best choice for every treatment. So we need personalized concepts on all levels. Elisabetta mentioned diagnostics as but also surveillance. Let's say to screen everybody may not be the ideal approach in each country. We really have to individualize here the concepts. And when you just look at the natural history, this is where we compared B versus Delta. The question is really, which are the factors determining if a patient develops HCC, decompensation, or death? Because some patients may have a rather mild disease. Not every patient is developing endpoints. And therefore, we need tools to stage the disease, to predict patients with a higher likelihood of disease progression. And I have to highlight two publications which I think are really important for clinical practice. The first one is that Lisa Sandman and colleagues from different centers in Europe really showed that liver elastography is a very useful tool, a robust tool to stage fibrosis, and these have been the cutoffs that have been established in that paper. So to decide, does a patient need urgent treatment, yes or no, elastography is sufficient. It's a robust method. The second point is obviously which methods really predict clinical endpoints, and I have referred here to a paper by Matthias Jachs and colleagues from Vienna and Hanover, who really show that non-invasive tests predict endpoint developments in advanced HDV cirrhosis, including portal pressure gradient measurements, a very nice paper. But this is important if you want to personalize treatment approaches. And just to add one point to Elisabetta's very, very important comments on issues on HDV RNA testing, one answer to her issues were, well, we still have a WHO standard. You may just calibrate all your assays with extraction methods, etc., to the WHO standard, and then all problems are gone. That should be or you have a conversion factor or something like this. And I want to highlight one point, that Delta is really variable. And even if you use different assays, these are published here, two different Robogen assays, 2.0, 3.0, and with different extraction methods, you can see here if you apply these four tools or combinations with the WHO standard and dilution, this works quite fine. And for some clinical samples, it also works quite fine. But in other clinical samples, these were random routine clinical samples, you have suddenly huge variabilities, more than 2 logs in some cases. And this really shows a problem. There will not be a conversion factor related to the WHO standard to overcome this problem. This is why do I spend time on this? Because when we talk about treatments, don't switch between assays. You cannot predict whether this patient or this patient or this patient is, or in which group this patient is. We have to stick with one assay, and there will not be, like in hepatitis B, when we start treatment, let's say with a cutoff of 2,000 international units, then you have to think about treatment. We will never, ever have one HDV RNA cutoff 1,000, 10,000 to decide to start treatment, yes or no. This will never work in Delta. We have the final point we have to consider that Delta is really heterogeneous. We all know that Delta is heterogeneous. We have the different genotypes in Africa. The point is that even the point when to decide antiviral treatment, this may differ in different regions. Annika Wranke just published data from the international network registry, where she could show that the outcome, the likelihood to develop an event over time is different if you look into different regions, Europe versus Africa, versus Pakistan, versus South America. So this is another point we have to, that there is not one size fits all treatment. We have to be flexible. Which treatments do we have? We should not forget that these patients are co-infected with B, so that we should apply HBV treatment approaches. At this stage, we have interferon, we have bulevirtide, we can combine them, and then we can evaluate alternative treatments in clinical trials, and we'll mention some of them in the end. Interferon. I think what has to be highlighted, we have a huge experience with interferon, and it's a well-established treatment options. And it should be used when bulevirtide is not available. We'll spend a lot of time talking about bulevirtide, but there may be people watching this webinar where simply they do not have access to bulevirtide. And therefore, guys, don't forget interferon. We know some host and viral factors which may predict response. We even have weak data on some kind of response-guided therapy, which we have been using in hepatitis C treatment quite some years ago. But it's a drug where we should remind ourselves what has been generated in evidence. We know that roughly 25% of patients may achieve HDV RNA suppression. We know that there is relapse after the end of treatment. We know that there may be even late relapses after several years. This has been shown by several sites. So if you treat a patient with interferon, follow your patient. But the most important point is, if you treat your patient successfully with interferon, you're doing a good thing, because there have been several cohorts, Pietro and the Milan team published this 15 years ago, and other people later, that if you are HDV RNA negative after or at the end of treatment, and even if you have a late relapse, you still have a good response, while if you do not achieve a response, you have a higher likelihood to develop clinical complications. And there are factors which may guide your decision points. These are some summarize this. Cirrhosis is not a negative factor for interferon response, and so on. I refer to this paper if you have to use interferon. But now let's talk about bulevirtide. You all know that bulevirtide receives conditional approval by EMA in summer 2020, full approval in 2023. It's available, meanwhile, in several European countries. There are differences in reimbursement practices. So it's in some countries only, let's say, kind of compassionate use programs, and others you have to ask the insurances, and others you can just prescribe it without asking anybody's. It's a quite, let's say, diverse pattern of approval status, which changes every week in Europe. To remind those guys who are not working on a daily basis with bulevirtide, it's a peptide targeting the pre-S1 region, which is a binding site for HBV, HDV receptor, which is NTCP. It specifically binds NTCP, and therefore it's also very safe because it's only targeting hepatocytes. It shows a strong inhibitory potential, and again, it exclusively targets liver parenchymal cells. It's a peptide which needs to be injected once daily. This is important. We have data from the phase 3 registration trial, a trial that compared 2 versus 10 milligram of bulevirtide daily injections. There was one referred treatment arm. The primary endpoint was 48 weeks of treatment, and the primary endpoint was a combined response, virological 2-log decline with ALT normalization, which were achieved at that time in 45% and 48% of patients respectively. And this basically was the basis for also full approval by the European Medical Agency. The 96 weeks data have just been published in the Journal of Hepatology, where you could see this with continuous treatment, the number of patients being virological responder increased, and after 2 years of treatment, only few patients, less than 20% overall, did not achieve at least a 2-log HDV RNA decline. You can also see that ALT normalization was achieved in almost 2/3 of the patients after 2 years of treatment with bulevirtide after 2 years. It's important to highlight that this treatment is associated with improvement in clinical markers. Liver stiffness improved. Pietro and his team and Elisabetta showed already 2 years ago that markers of portal hypertension improved in 18 patients with significant portal hypertension, which I think is very nice. Elisabetta then presented at EASL a very large cohort of 167 patients recruited at 37 centers, basically confirming response rates that were observed in the phase 3 clinical trials. And these were all patients with compensated cirrhosis. You can see here these respective numbers with a virological undetectable rate, virological response, biochemical response. Remember, I told you that 64% had normal liver enzymes after 96 weeks in 301, and Elisabetta presented 63%. And so the numbers are quite remarkable, even in patients in compensated cirrhosis. What is then important that there is not always 100% link between virological response and biochemical response. In our German experience, we still had patients, even at patients who did not achieve a complete virological response, we had remarkable improvements in liver enzymes. That is important. And when you have a closer look into the clinical registration trials, and Pietro presented an analysis where different HDV RNA cutoffs were evaluated, and then they look into the biochemical response rate. So if you have a patient who has undetectable HDV RNA, you can see here that 86% of patients had ALT below 1.5 upper the limit of normal. But even a patient who had only below 10,000 units of HDV RNA, you still have 83% achieving this biochemical response. So there is no strict correlation. And for us in clinical practice, guiding treatment on bulevirtide treatment, for me, actually, ALT is more important than HDV RNA, which is also some question, Maura, we may discuss in the panel later on. The other point that Elisabetta demonstrated at EASL is really important. She tried to match her patients with a historical control group. And this analysis suggested that there may be a benefit in terms of clinical complications by bulevirtide treatment in the long-term outcome. This does not look too dramatically, but if you look in this table, you can really see that the number of patients achieving who started off with Child-Pugh A5, who had then after 2 years hepatic decompensation. There was not a single patient in the bulevirtide treatment arm or group that achieved this clinical complication, while this occurred in the untreated cohort. So there seems to be a rather early effect already on decompensation. This was not seen for HCC, and Elisabetta may comment on details on this important study. What is also for clinical practice important, what is happening if a patient with decompensated hepatitis D, which I think is also very important. And Christopher Dies-Fricke summarized from different centers data here in this group, and he could show that if a patient started off with Child-Pugh B stage, that half of them improved the MEL score over time, which I think is clinically highly relevant. And to me, even though bulevirtide is officially approved only for patients with compensated liver disease, ethically it may be difficult to withhold this treatment from patients with decompensated cirrhosis. Bulevirtide and interferon, there may be synergistic effects on HDV RNA. The advantage of this combination may be that we have also some effects on HBs antigen, while bulevirtide monotherapy does not induce any S antigen decline. The data have been presented by Tarek Asalat last year at AASLD. of this combination trial, which compared early combination with a tail of bulevirtide monotherapy. The primary endpoint was what week 100 off treatment response. And here, these are the basically HDV RNA undetectable rates. You can see here that this was at this stage quite remarkable. And this suggests also that the 10 milligram group might be better than the 2 milligram group. The final data have been published in the New England Journal of Medicine at released during EASL and refer to this paper, as I don't have time to discuss details here now. I think it's quite important and impressive data that for a subgroup of patients, combination may be beneficial, but keep in mind that we only have 2 milligram available at this stage. We cannot prescribe 10 milligram. The question then arises, can bulevirtide monotherapy be stopped? Pietro and his group published this very important case where Maura Dandri contributed with this very nice intrahepatic stainings, suggesting that indeed with continued monotherapy, then if you put a needle in this patient, delta was cured, even though S antigen was still present. So is this only a single patient? Does this occur more often? From the 204 study, we have now additional information because there was this group with monotherapy with 10 milligram who were then also stopped after 96 weeks. And you can see here at the end, of treatment after 96 weeks, 22% of the patients had undetectable HDV RNA, and indeed some patients maintained this after in the long-term follow-up. There were relapses, yes, but also in the other groups where you could see relapses. So in single patients, an off-treatment response can be maintained. Just some final words on the drugs in development. Interferon lambda, unfortunately, had to be stopped because of flares, so we don't have data on lambda. We have data seen on siRNAs against HBs antigen. If you use this alone, it works in principle. S antigen declines and also HDV RNA declines, but we have seen in patients with high HBs antigen levels flares in ALT, as you can see here. These were no beneficial flares in the long term, but when you stop treatment, you can see here that these flares disappeared. This is something which needs to be taken into account, but if you have patients with low S antigen levels as baseline, long-term treatment may be an interesting option, which we presented this year at EASL. Then there have been data on siRNAs against HBs antigen in combination with anti-HBs monoclonal antibodies. The VIR data have been presented by Tarek Assalah during EASL. Also quite interesting response. You can see here the combination group of the siRNA with the monoclonal, quite impressive HDV RNA declines, also ALT declines. You can see here the number of patients being undetectable or having very low levels of HDV RNA at week 24 is really impressive, I have to say. A very interesting treatment opportunity. The interesting point is that also other monoclonals against S antigen have been tested in Delta. We've seen here the BJT778 data at EASL at a late-breaking poster. Also here, very impressive HDV RNA declines in these patients being treated with 300 milligram of this antibody. And we have seen the year before an anti-PS1 monoclonal antibody by this Chinese company, also showing quite impressive HDV RNA declines. So the concept that a monoclonal may reduce S antigen and HDV RNA has now been shown for 3 different antibodies. We have seen nucleic acid polymer data quite some years ago in a paper, the first 11 patients published in Lancet GH 2017. We have seen several case reports presented during recent meetings, no full paper yet. Interesting approach, which we may discuss during the discussion. And this is basically my summary of the ongoing clinical trials. Lonafinib, where the phase 3 trial has been completed, but no further trials are currently planned. To my knowledge, Lambda, I mentioned the phase 3 trial had to be stopped. Nucleic acid polymers, we have seen additional case series during recent liver meetings and have to see how this will be further developed. For the other approaches, the as the strategies are basically ongoing. So my summary is, and for the discussion points, I think that interferon should not be forgotten, in particular if bulevirtide is not available. Bulevirtide is approved by EMA. We see virological and biochemical responses in most patients. The issue how long to treat can be used in every decompensated patients. After having seen the New England Journal paper, now when to combine it with interferon, we may discuss during the discussion round. We have these additional new treatments which are in clinical development. And this is a teaser, this meeting here. If you want to discuss this in more detail, you need to come to Milan. Pietro may comment on this very nice meeting, the third Delta Cure international meeting, which will take place this year on October 11th to October 12th in Milan, again, hosted by Pietro Lambertico. And I thank you very much for your attention. Would be happy to discuss some of these points. And sorry for running fast through the slides, but Maura, there are a lot of data. Sorry.
Yes, you're right. Thank you for this overview, Heiner. I know it was a challenging talk. So, Massimo, what do you think?
I will take the lead now and open the roundtable discussion. Let's introduce briefly the different participants. So we start with Dr. Dandri. She is a co-founder of and head of the Onum Foundation in Mongolia that has played a very important role in shaping the public policies on hepatitis C, hepatitis B, and obviously hepatitis Delta in Mongolia. And it is important to underline that it was really a big achievement to transform activity into policies, and this is very, very important. Pietro Lambertico, I don't know whether he really needs introduction, is the professor of gastroenterology in Milan, and he leads the department of the Center of Liver Disease and Pathophysiology and Transplantation, University of Milan. He's been a leader in hepatitis B and hepatitis Delta lately, clinical research. And I think I have not to say anything more. Professor Nguyen is the director of the International Network and the head of the virology department in the Institut Pasteur in Cameroon, and he formed in France. He has a PhD in addition to the medical degree, and he has been part of the development of WHO guidelines for viral hepatitis as well. And finally, Fabien Zulim, that is like me in Lyon, is a professor of gastroenterology in Lyon, is the director of a research unit of viral hepatitis at the INSERM here in Lyon. He founded the Lyon Hepatology Institute. And I think I have not to underline more his contribution to hepatitis B and hepatitis Delta research. Having said this, I would start asking the four panelists to eventually talk one after the other and point what was for them relevant to discuss in the three presentations we have, while Maura can select the first one or two questions from the chat and the Q&A section. There are several, and then eventually I will ask myself some questions. But I think that the most important point is the panelists trying to challenge our speakers. So let's start with Dr. Dandri from let's say the Mongolian perspective, or the Asian perspective, or the Delta perspective in a highly high prevalence country.
Thank you for the nice introduction, and thank you for all the nice presentations. This was really wonderful, especially having the WHO. That makes it really nice. So as you all know, that Mongolia has now I think a lot of papers actually came out really showing that Mongolia has the highest burden in the world. So we are really having issues from the testing to the treatment. And treatment is being one of the really urgent problem. And I also see on the questions from Kyrgyzstan asking very similar questions. We have at least a drug two drugs that does something. Especially the bulevirtide obviously makes great change, that it's especially not having a lot of side effects. Despite its being a long-term treatment, this really makes a huge difference. And we would like to have the drug on the ground, but we are really struggling to get it. So just to put it in perspective, so the Heiner did really nice presentation, and then one of the thing really given me like quite difference was that Heiner was saying on the presentation on the slide that with the 176 patients, huge data set. But I can tell that in my clinic, it's a small clinic within Mongolia, we have 4,300 patients who have HBV RNA positive. They need treatment urgently, but we do not have treatment. And now we have some drugs on the ground, but that the pricing is that bulevirtide is now, official pricing is $2,500 per month. Whereas the income of Mongolian people is around $300 per month. So for 1 month treatment, you need to earn almost 10 months salary. So that's just does not work. And there are some negotiations going on. But what we hear is that with the negotiations, it's only coming down possibly to $1,000, which is again 3 months salary. It's not affordable for most of our patients. So I wanted to ask Nicholas, is there any plan for WHO to kind of facilitate and to have some sort of a framework to make these drugs available for these patients, especially because we do not have any other choices? The country like Mongolia, for example, government put some money aside. Now we are purchasing for the first time 250 patients peg interferon. But that's for the first time. So it's still some positive movement, but it's not enough. So that's what I wanted to ask. The second question for the Nicholas's presentation was that also Elizabeth's presentation, there are a lot of this new testing diagnostics are being developed, but if you go through all of the pre-qualification procedures at the WHO level, it's very, very slow and very bureaucratic process. Do you have any plans for making it, especially for hepatitis delta, do you have any plans for making it a bit more expedited, like orphan drug, similar type of orphan testing, approval process, etc., something similar that utilized in the SARS-CoV-2 epidemic? So these are the two questions that I feel that probably needs to be asked. Thank you.
And just before Nicholas answers, there are also some questions in the chat that went into the same direction. What can be the strategy to allow access to these drugs that seem to interferon is a little bit a different problem, but for bulevirtide we really saw the implications of the role in treatment. But what are the strategies? What can be done? Are there discussions at which level? And eventually also John, if he has elements to add, perhaps would be nice to hear from you.
So I think it's for me to start. Is it right, Massimo?
Yeah, if you can.
I unfortunately think there's not a very easy answer to that. I think I would just remind everyone in terms of, WHO cannot be engaged in direct negotiations with manufacturers of it being diagnostics or drug companies. I think what we generally contribute to, let's say, the space is that we have recommendations and that we can be part of partnership efforts to bring pricing down or highlight efficacy and awareness around certain issues. So I think the first thing here that we all have to do, that doesn't respond to that question, but is to continue to increase the advocacy and awareness about the importance of hepatitis delta. All our presentations pointed to that. Now, in terms of drug prices, it is really mostly to the countries and the negotiations with the pharma companies. Here for bulevirtide, we're talking about one specific pharma company to negotiate those prices. And I think they should depend on the income level of a country, right? And the margins and for the company and the prices for the country should potentially vary in low and middle income countries. Now, if we're thinking back to hepatitis C, for example, where we started with incredibly high treatment prices, I think as well, one thing that really contributed, that wasn't the only effect, but was to put pressure on the companies who were producing those drugs on highlighting those from civil society, patient groups, countries, highlighting the importance of making this more widely available and not only in high-income countries. There is now, to finish, and then good to hear from John, there is actually a mechanism in Geneva-based that is not linked to WHO, which is the Medicines Patent Pool. And the Medicines Patent Pool can coordinate with pharma companies around voluntary licensing. So that would be a mechanism, where a company grants for a specific drug a licensing mechanism for generic manufacturers, for example, to produce, if the drug is still under patent protection, to produce that drug for access prices. And everybody possibly knows that this exists for hepatitis C, for example, and several combinations, and covers more than 100 countries for sofosbuvir, daclatosvir, for example. So that would be an existing mechanisms, but I don't know that bulevirtide, we are there already, in terms of what we know about this drug, how much it costs, the engagement of the manufacturers to make this mechanism available. But we should have this discussion with MPP.
John, do you have any news about because now the mechanism?
I don't have any news.
The important point is something going on.
I just want to champion, many of Nicholas's comments. I mean, I think the evidence is growing in strength to have a compelling case for why this drug needs to be available in countries such as Mongolia, and then we can begin to get MPP involved and speak directly to the manufacturers. Gilead has an excellent record of making their medicines available via generic manufacturers. So I think it's a great opportunity to develop a public-private partnership, and the coalition can definitely, have a role in that. So I, look forward to seeing how we can solve this problem over the coming, several years. It's going to take a little time, but I think the evidence is really strengthening the case for why there needs to be more affordable options for high-burden countries such as Mongolia. I would like to think, Maura, that the move of the government to support some hepatitis delta testing and treatment is a positive step forward. Just they're beginning to hear the message that delta needs treatment. So I think I see that as a positive step. Do you agree?
Absolutely. This is a positive step to the right direction, but it needs one of the really big problems with the hepatitis delta patients is that they are really so quickly progressing, and they are the people who are actually very young people. So I think we need something not in years' time, hopefully in within a year or two. So
Okay,
most
I hear you.
patients are really needing it
No,
very urgently.
So
No, thank you. Thank you. Let's move
before-
on to the other comments. I don't want to
yeah,
have
yeah, yeah.
panelists.
Before going to the some more medical or clinical questions, let's hear something from the perspective of Africa. What is moving around there? Whether there are specific questions from Richard.
So thank you, Massimo. Thanks also for the organizer for the invitations. And Amazonia is seems as Africa, because most of what she said regarding Amazonia is the same thing in Africa. But particularly in Cameroon, where I'm working, because I'm working in the National Reference Laboratory, where we have to confirm most of the people who are suspected to be infected by hepatitis delta infections. All the analyses are centralized. So people that are infected are mostly located in the remote area. And if they want to know the status, they have to travel from the remote area to the central lab. And I think that most of the big challenges is the testing. Testing also is a very big challenge, because I think that I have one question. So let's say Elisabetta, or it can be the same question for Dr. Nicholas, to see what is the challenge in developing rapid diagnostic testing for HGV. We saw that for HIV, for example, after 10 years of after discovery, we have many RDT testing, but now for HGV, 50 years after discovery, there are no commercialized as HGV. And the big challenges now for us is to decentralize the diagnostic, so that because infected people are found in the remote area, and which is very nice for us to, let's say, decentralize diagnostics, so that the testing could be done locally, and we could have the results at the center, the result at the central level very quickly, and see how they can take care of them. One of the second thing that I can think about is the data, the epidemiological data. I think that most of the epidemiology in Africa are underestimated, because the diagnosis of HGV is not done routinely. And most of the data that we have is just some sero survey that we did, for example, during, let's say, demographic health survey. The one that I published 2 years ago is the data that is used. But we are in an endemic area with people that we have more than 10% prevalence of hepatitis B, and about 10% of HBS positive patients are also HGV positive, and we have let's say a disparity in the prevalence regarding the geographic area where the people live in. I found more than 50% people HBS positive, whereas Delta positive, those are living in the forest area in Africa. So in summary, we need testing to, let's say, to give good data, and the data is very important if you want to think about eliminations, and also it's good to develop simplified and rapid diagnosis that can be used for decentralization. That's what I can say. Thank you.
So I would ask Elisabetta to provide a very, very short answer if she has a contribution there, because we want to hear from Pietro and Fabien and Einer, something specific that I will point out in a moment.
So thank you for the question. I think that the key point that prevented up until now the development of technologies, assays, was the lack of a definitive approved therapy. So with the field of drugs moving, I also think that the field of assay and diagnostics is still moving. So many companies are involved in developing new assays, and this will also in turn result into pushing development all of testing and also user-friendly tests. So this is my short comment.
So there is a long way to go. I think if the others want to do some fast comment on that. But the question for Pietro and Fabien and Einer eventually, and after they can do the comments as well, is do you think that there is hope to have bulevirtide as a generic? Because there are two situations for me. One is the chemistry, whether it will be easy to go for that, first point. Second point is for hepatitis C, everything was easier because it was a finite therapy that was having 90% or more success. So let's have the trio of the clinicians and virologist clinicians there. Just give us something to think about on how can be the development of more access to the existing treatments. After we have the new things we have from Einer, we can discuss hours about the side antibodies and the rep, but we will, and the NAPS, we will not do this today, probably. We have no time. So perhaps Pietro want to start, or Fabian?
Okay.
Fabian start, and then we will go to the...
Okay, so I'd like to thanks for the invitation and congratulations for the speakers. So my short answer is no. I don't think that the drug will be easily available as a generic. To my understanding, is a kind of complicated chemistry. So no, the answer is, my short answer is no. But I have one question for Heiner, which is related, of course, to clinical issues and stopping rules for bulevirtide monotherapy. Any suggestion?
That means how long we have to treat, in a way. That is linked also to the development and
Exactly.
of the market.
I don't know whether we should now spend 3 hours to discuss the stopping issue, or whether we first should. You
have 90 seconds.
No. But maybe let's first finalize the other. Pietro was very strong in saying that there will be no generic, and you asked the question, Massimo, on the chemistry, etc. Actually, in the end, it's easy. It's a peptide. It's a peptide with a little, let's say, modification, the mustulization. So it's no miracle to generate this peptide. So I was, even before bulevirtide was approved in 2017, 18, when I talked to patients, at that time I said, if I would be a patient myself at that time, I said, I would just ask the company in wherever to synthesize me the peptide. I would mix it myself and would inject it myself at that time. It would be life-threatening because theoretically, it's not that complicated to let's say, produce this peptide, but obviously there are patent issues, developing issues, administration, formulation, and you all may know that we don't have the approval by the FDA yet, not because of concerns regarding efficacy, but regarding all this production changes and quality, etc. So I don't know details, but it's not that the FDA was not convinced by data. It's all these QM issues. So I cannot comment on this. I have no clue whether there's a company starting things in parallel, but theoretically, in my understanding, it's not the issue, right? So
let's just make a comment, or let's hear from on the same issue from Fabian, if he knows something more or can add something different on the chemistry. And then eventually we will make one comment on that, because I think that is relevant.
No, okay, so thank you, Massimo. No, I don't know more about the chemistry, but I think we need to first to figure out pragmatic issues for the already existing compound, and I'm not talking about the generic. So there are issues about storage, as Einer was alluding to, issues with the reconstitution of the product every day, and the everyday injection. So there's a lot to be done if we want to improve what we already have, to have like a long-lasting drug, bulevirtide, with a pre-prepared syringe. So that would make already a huge change, and then we could think of generics and so on. So the other point to look into the future is that there might be some newer version with small molecules inhibiting viral entry that are in development. So it's a future. So this might be in the end the option to have just a pill, just a single pill instead of a peptide, which has all the issue of storage and stability and so on. So it's just a different perspective, but we know that there's a problem.
Yeah. Coming back to the chemistry, doing peptides is easy. The problem is to standardize. The modification is feasible. It's easier to modify one thing than build up a very complicated chemical structure for some of the compounds we see going around, like for an example, the NAPs. But on the other hand, what is very complicated is to standardize and to have a very, very well done purification of the peptides. This is what the machine is easy. I mean, even a small startup can do it, but then if you have to produce a big quantity, would have been nice to have Stefan here to comment on that, Stefan Urban. But because they worked a lot, obviously, on that. But the point that I see in enlarging toward a real generic, I think, is that different is licensing. If Gilead wants to go a certain point into that, and this is what probably the coalition and all the advocacy group should do, is to enlarge the access via a wise policy of licensing versus direct access to the Gilead drug at special prices. But this will be a long road, and I think the clinician, we have a few minutes for the last round, perhaps the clinician can just comment on the last point. How long? When to stop? What is there that is coming out from the data, the newest data? We have all these real life cohorts and all that say we have X number of patients, we stopped after this time, this is what's happening. What do you think? Let's give to the audience a kind of perspective today, because probably in 3 months we have new data.
Pietro, you should start.
Actually, the Heiner, the question was for you, so you have to start.
No,
you can ask Fabian to answer, but would be a job.
No, I think the point is, quite frankly, so obviously I wouldn't stop a patient that still has 500 units of HDV RNA. So ideally, the patient should be not detectable for HDV RNA. The question is whether there are very low residual dips of HDV RNA detection indicate really replication needs to be answered. But the data that we have seen thus far, in principle, this is possible. But the very big buts. I think this is things for clinical trials at this stage. There will be post-treatment flares in individual patients. Fortunately, in the clinical trials, there was no major, let's say, liver failure associated with flares, but we haven't seen data on 500 patients stopping. And if in 500 patients stopping, there may be 5 patients who really develop a problem. And therefore, I would be, at this stage, very cautious to stop outside of clinical trials. I understand that in distinct settings, resource-limited areas, you may not have the option to continue forever. And therefore, we need this data really urgently. It's not something of science that we're playing around. We need this data for safety of patients if they cannot afford lifelong treatment.
Pietro or Fabian, do we have something in the initial response in terms of RNA that can guide us to say that the patients is more likely to stay on response? Let's say, how fast you get non-detectable RNA. Are there data for that to start to build up on this, or in your experience there is nothing from your cohorts, from your trial?
I can make a comment for bulevirtide monotherapy. I think Fabian has a very good data on the combination. So For monotherapy, I think that, yes, the earlier you get PCR negativity, the more likely you will maintain PCR negativity. And then the more likely you will have a patient with like 2 years PCR negativity, and eventually he or she could be a candidate to stopping therapy. But unfortunately, the number of patients who achieve target not detected by week 12 or 24 on therapy is very, very limited. So if you want to reach 2 years PCR negativity, then probably you need to treat hundreds of patients for 4 years to get some with 2 or 3 years PCR negativity. That's monotherapy. Fabienne, you have very good data on combination therapy.
So with a combination therapy, well, we have to, with a caveat that the number of patients is not huge. We have to be very careful. So we have data also suggesting that the earlier the RNA is undetectable, the better it is, and so that the undetectability of RNA should be as long as possible before stopping. The other point is that what was shown in the combo study is that if RNA is detected below the level of quantification, then there's a risk of relapse. So again, so this come back to the point that was discussed. We don't have time today on the assays. The robustness of the assay will be extremely important if we want to have a response-guided treatment, and that's a must. We need to improve the assay and standardize the patient monitoring.
Maura, I give the word to you.
Yes, so at least the good news you can say from the study that we are all seen, it's somehow that if we don't see for certain time in the blood the virus, at least with boulevartide, it seems that there is also no more there in the liver. The question is how long you have to be negative to be quite sure that you have good chance to be really negative or to control the disease. So it's a very difficult issue. Unfortunately, we didn't have really much time to discuss so many aspects. So we will need more, I think, of this webinar and opportunity to discuss, because it seems that we need to act together, I think, to increase a coordinated screening strategy. If we don't have a screening, we don't know what's the burden. If we don't know the burden, at the end, we will not know how it is important that we keep developing better drugs and how to apply and to implement, and with need to be approved also for boulevartide, not having FDA approved, still it's some problems, some issues, and I think we need better drug, especially for the endemic countries. So this is a discussion that we cannot end here or resolve, of course, here. But it's something that I think we are, all these coalitions and people and company needs to be aware of and keep working on that because people really suffer of this disease. Even if, Einer, you mentioned we have interferon, it's not always bad. It does something, but the hope, we still need interferon to be used in combination. This will be also a topic of a symposium that we will have in Chicago about trying to understand the still ongoing utility of interferon that also organized from ICE-HBV. So there is a lot to discuss about B and D and the good of having still interferon. So we need to work a lot, I would say. I don't know if we have maybe still the last final slides, but I guess we don't need, because John Ward already mentioned is going to be recorded, everything has been recorded and to be available, the presentation. And just to mention, the last year webinar has been viewed more than 6,000 times the last months, so in the last year. So it seems that they are well taken. We had around 100 people today, but still afterwards there is a prolonged effect, sustained effect, I would say, almost, just to stay in the term. So, and I think with that, I would like to thank very much organizations, the speaker and the panelists. It's very important to have a lively discussion, contributions to this topic. And I would say just thank you very much. to my co-chairs, to everybody. Stay tuned, and we hope to keep, well, to have even better news next time.
Maura,
Thank you.
if I can.
Would you like to comment? John, Massimo, for you, the last word.
Just 1 second. I would prompt Lindsay to download somehow the webinar chat and the questions, so we can eventually have a post-webinar effect. If there are some really pointed questions that may require an answer for somebody, we will still use the panel and the presenters to provide answers that have not been provided. We did that for another webinar. It worked. It was not so much work. If we do a little selection, I will provide that if the organization can download it. I have no other. You perfectly.
Yes, of course. There were many questions. You're right. The situation in China, in Africa. Yeah.
Last word again to John.
Yeah, that's great. We covered a lot in 90 minutes. It really shows the really the positive news around the benefits of treatment for Delta, and we're now returning to equity. You know, how do we begin to make this effective treatment available broadly to the countries that need it most? And so I think it was a very, very healthy discussion. Really pointed us in the right direction. Speaking for the coalition of our role in achieving health equity for treatment for persons with Delta infection. So again, this information will be available on our website, globalhep.org. I want to thank again all of you and ICE-HBV for working together for this webinar, and look forward to continuing to work together to improve access for hepatitis B diagnosis and treatment, as well as Delta testing and treatment. Thank you all.